G'day and welcome back to the GPSA webinar series. My name is Glenn Wallace, I'm CEO of GP Supervisors Australia, and tonight we've got your latest webinar session on how to teach your registrar about young people with depression. And with me tonight is Claudio from Headspace, so he's going to be running you through this particular topic, and I've got a couple of housekeeping items to run you through first. As we do customarily, we acknowledge the traditional owners on the land on which this meeting is taking place across this large country of ours and pay respects to their elders past and present and their families. So thank you for joining us. In terms of webinar housekeeping, if you have not joined the GPSA webinar before, just be conscious that obviously with a large number of participants, we couldn't have everybody speaking, contributing. You'd all be talking over one another. And so for the ability of the presenter to get through the content and make sure that everybody is muted quite on purpose to ensure that the background noise is managed as well. That doesn't mean that you can't engage with the webinar and the presenter. Please do. You'll be able to ask questions in the chat box. You should be able to see a little indicator there on the left prompting where you're able to add your questions and talk to each other throughout the session. We're also recording this webinar for anybody who's unable to attend and engage with the content tonight directly. So never fear, if you've missed this, you'll have an opportunity to engage with it at a little bit later date. Now, other items, if you haven't engaged in one of these webinars before, down the bottom right, you'll see highlighted at the moment is a little folder. In that folder is a copy of this webinar, all of the links that are associated with this particular webinar, and other useful resources from GPSA. As they come up, we'll make sure that they are highlighted in the chat box also, but please do have a look through those. At the end of the webinar, we will ask you to evaluate this session and give us some feedback. We're always looking to improve on what we do. And we'll also make sure in the weeks that follow that you receive a copy of all of the links, the PowerPoint and the webinar recording also. Okay, so without further ado, I'm going to pass over to yourself, Claudio. If you could tell these good people a bit about yourself.
Great, thanks, Glenn, and welcome everyone. Thanks for coming along, and thank you very much for having me. So I'm a GP. I've been working exclusively with young people for over 15 years now. I started working in the first Headspace Centre about 10 years ago in Sunshine. Did that work for about 8 years. In the last 5 years, I've moved into a role in the Headspace National Office, supporting general practice within the Headspace model. And the reason that I have put this particular presentation together, this workshop, is to highlight some of the issues that I'm aware of in terms of young people coming to Headspace, presenting to Headspace after having been to see a GP in the community. I'm aware that there's a lot of practice that sits well outside of the guidelines. So in terms of that, really, then one way that I view about this is an opportunity to highlight what the treatment guidelines are for young people with depression, and using that as a way to talk about some of the other issues that come up with young people, and really. It's really just a reminder that the treatment guidelines, they provide a path for us to follow. And if we do that, I think if there's something goes wrong and we have to justify our approach, it's much easier to do that if your practice is broadly consistent with the guidelines. And if you're acting outside of the guidelines, then there's potential to be criticised or for it to be on a treacherous path, and we want to avoid that. And I think that there's not very good awareness of the guidelines broadly in terms of treatment of depression in young people. So, and depression in young people, why are we talking about that? Well, if we look at 12 to 17-year-olds, then about 5% overall will have had a major depressive order in the last 12 months, which is pretty significant. And if you put that in the context of 1 in 4 young people having impacted by their mental health in the past year, it means that many of the young people that you see, for whatever reason that they present, will be struggling with some mental health issues. So it's a real reminder that it's an opportunity to engage in broader engagement and assessment of young people that present. And also, in terms of recent paper looking at registrar interactions with young people, depression was the most common mental health presentation that young people present with GP registrars with, at 32%. And really interestingly, GP registrars are twice as likely to refer young people than adults for mental health issues. And this paper looked at some of the underlying issues that are responsible, and low exposure to young people is a really interesting one, and therefore lower confidence by registrars in terms of managing young people, and they're spending less longer consults with young people, and also parental pressure to refer. So I think all of these things point to a need for greater exposure for registrars to have with young people, and they need support to build confidence to be able to confidently manage that. So that's kind of why we're here, I guess. So to talk through this, I'm going to run through a case. This is a young woman, Sarah, who I saw a few years ago. She is 15 years of age and brought in by her mum. Sorry, I'm just going to adjust my screen there. And she's in year 9. So she attended with her mum, Linda, who reports that Sarah's had a 6-month history of anxiety and depression. So she describes Sarah as irritable, causing a lot of family conflict. And Sarah's had 6 sessions of counselling, which mum says didn't help. And when you try and engage Sarah a little bit, it's pretty clear that mum's going to answer all the questions, even though you're directing them at Sarah. And within a pretty short period of time in the consultation, Sarah's mum, Linda, bursts into tears, stating Sarah needs to be put on antidepressants. So that's all happens in the sort of first 5 to 10 minutes of the consultation. So in terms of how do we, I'm just curious to see what people think about how to handle the situation from here and what people's usual practice would be to do. Feel free to give some feedback. Otherwise, I might just run through. There are some pointed questions. I can't see if anyone's typing there. So just in the interest of time, I might just continue on. So in terms of, what I think it's important, and I think most of us will agree that it's really important to spend some time seeing Sarah alone. And in terms of that is so that we can really, otherwise we're only going to get a history from Sarah's mum, because once that picture's outlined, it's pretty clear that that dynamic will continue if we don't do something to interrupt it. And how we do that, I think a piece of advice that I have in terms of discussing the sort of the limits of confidentiality. It's a really important conversation to have up front, and it's really important to have it with both the young person and their family and friend in the room, because then everyone hears the same information, and it's an opportunity to clarify any questions or concerns around that, and particularly around the limits of confidentiality, so that you're very clear that what you discuss is confidential. But if you have serious concerns around safety, of course you will need to breach confidentiality and describe how you'll go about that. And the other important thing in terms of that is that confidentiality. I think sometimes people think it's an all or nothing thing, but it's really important to clarify with the young person what things they are happy to have shared with the support person and what things they're not, and to see if that's reasonable and achievable. And that way that they should feel empowered and engaged and like they've got a say in things. So in terms of the findings on history, and after getting Linda, her mum, out of the room, Sarah presents much more as very easy to engage, and she opens up. And she agrees that she's been feeling depressed, she's been feeling anxious, she's been angry, she's been irritable, not doing as well at school, and fighting a lot at home. This has been going on for at least 6 months. Any thoughts on what other things we need to find out about? I think this is all fairly straightforward. So I'll just run through. I mean, basically, I think the most important thing. If I've got someone typing there, maybe is that a comment? No, I can't see anything there. I'll just continue. So in terms of, so the heads assessment provides a nice, easy framework for us to engage with the young person. And if I maybe give some feedback around what some of the issues were, I'll use a formulation framework to help make sense of what's going on for Sarah. So in terms of predisposing, it turns out that mum's got a history of depression, so that's an important piece of information to have in that. She's had a precipitant of a falling out with a best friend at school, so there's been a complete breakdown of that relationship, which is really impacting, and sort of happened just before she started to have a decline in her mood, and perpetuating issues that there's a lot of family pressure in the context of mum and dad who are increasingly fighting, and Sarah says that mum is really stressed, and all of this really makes everything at home pretty difficult to manage, particularly since she doesn't feel good, she's not very motivated, and she's irritable. So all of that kind of interacts in a bit of a vicious circle. Protective factors, there's no, Sarah's very clear she doesn't use any alcohol over drugs. She feels very well connected to her family and supported, and she loves her family. She's very bright and intelligent. She's doing well at school. What is very important to check in terms of the HEADS framework in this context where someone is got this kind of array of symptoms going on? Any thoughts from the audience? I'll just, so of course the thing that's really important to check is risk of self-harm or suicide. Okay, I'm obviously having some trouble seeing the chat box. Yeah. Hang on just a second.
Sorry, Claudia, can you hear me?
Yeah, no, I can see the chat box now. I must have had it clicked on the wrong one.
Okay, great, cool.
Okay, so I'll just take back some of the. I'm very sorry about that. So Sarah's made a comment, and Lisa's made a comment about explaining the usual approach, and I think that's really important in terms of explaining to Linda about getting Sarah out of the room. That's just a usual normal practice, and that it's very important to see Sarah alone with her consent, and of course it's important to check with Sarah that she's happy to do that. well, she was able to access. She saw that there's a question from Margaret about how was she able to access counselling because their public primary mental health services are only prepared to see people over 16. Well, that's surprising to me. I'm used to many young people accessing counselling, as a mature minor before the earlier than age 16, which she had done privately. She'd accessed a counsellor privately with consent from mum. Then Sarah, in terms of doing the assessment, so yes, so all of the stuff that we've talked about, people have offered up in terms of it being really important to do a heads assessment and to use that as a tool to engage more broadly about the context of what's going on. And of course, the thing that's very important to check is both safety in terms of self-harm, suicidal ideation, and thoughts of harm to others as well, of course. So I think that covers. We've got up to speed. Sorry about that. I'll continue on, but we're on the right track now. That's great. Findings on examination in terms of mental state. Sarah's well engaged and insightful, but she does clearly have lowered mood. She's anxious. She has thoughts of hopelessness, which is concerning, although she doesn't have any thoughts of self-harm or suicide. So, which is great. So we check directly about those. In terms of on physical examination, usually offer young people to have a basic general physical examination as part of their, engaging, an opportunity to engage about their physical health. And on physical examination, quite dramatically, she had this quite large 6-centimetre wound right down to fascia on her left upper arm. And I asked her about that. She was very minimising of it and saying, "Oh, I just pick at that." So, and then I was checking about her understanding that I'd asked her about harming herself. She clearly didn't see this as self-harm. It was just a habit that she had got into as a way of managing her distress. So, and then when I'm asking her about that, does mum know? Oh no, mum doesn't know. She has seen it previously. She doesn't know that it's this big at the moment. I really don't want you to let mum know. I don't want you to talk about that with mum at all. This is the first time I've seen Sarah or her mum, and the wound is really very impressive, and so I am a bit concerned about it. So I'll just do a poll question. Noting that Sarah does not want me to discuss the wound with her mum, do you think you're able to keep this confidential? And I find this situation where young people don't really view a behaviour as presenting any risk or as being a way of harming themselves as pretty common, which is a bit challenging because it raises some concerns about their level of insight about what is going on. Is there any last takers on that before I stop the poll? We've had a good number of responses. So I'll just stop that there. Any last takers? So I'm just not sure how to share the poll, but I'll just read it out to you in terms of if everyone can see that. If I untick anonymous, does that do it? So the majority of people said that they were unsure, with and then a bit of a mix with more yeses than no. So, you know, this presented a bit of a dilemma for me, really because it was the first time that I had seen Sarah or her mum, and I was quite concerned about what would happen with the wound. But, you know, it wasn't infected, it's not life-threatening, although I was a bit concerned that she wanted to hide it from mum, and it presented a practical problem for me in terms of it would be really good to make sure this wound's being regularly attended to. So I was keen for mum to know about it because I thought she would be able to help assisting with making sure that the follow-up would all happen, since they've come some distance across town. Mum's driven her over, etc. So what I decided to do was to give Sarah the option, explain to her that I was concerned about the wound, and I'd probably feel more comfortable if mum did know about it, for those reasons that I've just said. But if she really didn't want me to discuss it, that I could do that, that would be okay, providing she turned up as we agreed for a review of the wound to make sure that it was progressing all right. And if she didn't do that, then I would need to let mum know. So she had a bit of a think about that and came back with, okay, you can tell mum, that's fine. I don't mind. So that's kind of how that played out. So thinking about what things might be going on here. So what are the things we need to be assessing for in this context? Any ideas from the audience? And what about comorbidity? So what are the other things that we need to be thinking about? So I guess I was concerned in terms of part of the picture was a decline in the school function. So I'm always concerned about this might be a very soft presentation of early psychosis. Some people, so Lisa's suggesting some medical conditions, anemia and thyroid disease. I think that they are other medical things that are very reasonable things to think about. I was also concerned about the picking at the wound might have sounded a bit compulsive, so that there might, so I was thinking about, could this be OCD? Mum's got depression, so depression seemed like also seemed like a pretty good fit. So other things to think about in a young woman presenting like this are eating disorders, so needing to make sure that you're screening for eating disorders, making sure that you're asking about alcohol and other drugs as well. And iron deficiencies come up as another medical cause that might be explaining some of what's going on here. And I think that they're all reasonable suggestions. So in terms of what messages giving Sarah, I think it's a really important opportunity to really give some strong messaging to Sarah about she's come to the right place. It's really important. You're very concerned about her wound. You want to follow up with her. It's really important that she comes back and continues to see you regularly, and making clear that she's your patient, that mum's not the patient here, and you'll be able to see her alone if that's what she would prefer to do, ongoing, all of that stuff. And in terms of mum, I think it's really important to give clear messaging, similar messaging, that it's important to follow up with Sarah. You agree that there's plenty to work with here, but that you're seeing Sarah as the patient here, and it's important for mum to follow up with her care, which in the context of Headspace is a little bit easier because mum can't be the primary patient because she's outside the age range. So it makes it a little bit easier to sort of create those boundaries. So the clinical impression after further assessment was that, just to sort of cut to Margaret's made the comment about encouraging mum to have her own GP, and certainly there was a discussion about that, and she does have a GP, so I encourage her to go back and see her. So clearly, Sarah probably met criteria for major depressive disorder, possibly generalised anxiety disorder as well, because she was also pretty anxious about lots of stuff. And sorry, there's another comment around, it can be very difficult. His mum is actually your patient, which is certainly adds complexity, typically in general practice around that dichotomy, that sort of issue. So, mum's really, I'm coming back in, she's really applying a lot of pressure about that SSRIs are the solution. So just putting up another poll here. Would you consider prescribing an SSRI for Sarah, noting that the previous counselling didn't help? So we've got a very even mix. So Darren's made the point not at first content. A couple of people have said that, so there's a bit of a theme about not on the first visit, and I think that's not without a psychiatry input. So in terms of the spread of responses, there's very evenly split between yes being first, maybe no, and no. So maybe second and no third, with not a lot between the choices there. So there's some comments here which are very heartened by that they are in line with the guidelines. So I'll just run through those. So the trick in this is that she's had some previous counselling. So from a criteria point of view, that's important. So she's actually had some CBT treatment. But what further information might be really helpful to know about this treatment, which she hasn't found helpful? Okay, and there's a comment here about exploring what the counselling was, what was useful, what wasn't. So yes, so I think that it's really important to engage the young person around what that counselling involved and how they found it, how many sessions they have. So she had 6 sessions. When I asked her, so we need to know why the counselling wasn't helpful. And when we ask Sarah, she's very blunt. I didn't like the counsellor. I didn't like her. She was always on mum's side. And when you tease this out, it becomes pretty clear that the counsellor had a lot of trouble managing the sort of mum overstepping the boundaries because she just seemed to find that quite difficult. And Sarah did not feel that she was actually on her side, which is pretty telling. So I would say that that's not a successful attempt at therapy. So I'm just going to say, what are the guidelines? Just a reminder about what the guidelines say about this. And so I'm just going to point to the Origin Treating Depression in Young People guidelines, and I'm going to summarise the key points here. So in terms of assessment, the guidelines say it's important to make a careful assessment over time. You need to use validated tools where appropriate. Make sure you consider the differential diagnosis. And in terms of treatment should be stepped or staged treatment. It's really important to have a shared decision-making approach, so we'll talk about that in a minute. And if you are going to use SSRIs, it's really important to understand the appropriate monitoring that's required and that's weekly for at least 4 weeks. And this is another point that I often saw young people who came to us after seeing external GPs and they were not getting the appropriate monitoring after being prescribed. So in terms of validated tools to help support a diagnosis, because one of the things we also saw is I've seen quite a few young people who've been given a label of a diagnosis of depression, but when tease it out, it doesn't really meet diagnostic criteria. So we looked at a whole range of tools to help assessment and monitoring, and we came up with a PHQ-9 as the best one because it aligns well with the DSM criteria. So if we look at and the benefits of using a validated tool like this is that it gives you a way of sort of objectively assessing the severity of symptoms. Some young people will feel more comfortable disclosing via a tool other than by history. You can also check your understanding of history, the consistency of it. So those are some benefits. There are some risks in terms of some people will be disengaged by this tool, so it's really important to seek permission from them. And you need to check that they understand all the questions and make sure that they can help with that. And it's not validated for all young people. So some cultural groups, Aboriginal and Torres Strait Islanders, sometimes there are specific tools that are more appropriate for the populations that have been adjusted. So it's just mindful to be wary of that. And it's got high specificity and validity for major depression at about 88%, which is pretty good. So if we look at Sarah's responses, this is where she scored across the range, and all up she gets a score of 16. And you can see she's had had little interest and pleasure. She's feeling down nearly every day. She's getting some sleep symptoms, feeling lack of energy, some impact on appetite, feeling bad about herself, and a lot of trouble concentrating. And here she's having some thoughts that she would be better off dead. So when I asked her previously about thoughts of self-harm or suicide, well, she said, well, I don't actually think about doing anything, but I just sometimes feel like I'd be better off dead. So that's adds a bit of further richness to the story as well. So if we look at around the severity scale, so in terms of the PHQ score, that puts her in the moderate to severe range, at the low end of the moderate range. So, looking at this is the guideline, this is sort of stage care and treatment. So it's saying that CBT is appropriate, and you might consider fluoxetine if necessary. For example, if 6 sessions of CBT has not been effective. But in this case, you would say, well, she hasn't really had an effective trial of CBT, so it would be worthwhile considering having another go. So specifically around SSRIs, so they're only indicated for moderate or severe depression, not mild, when psychological treatments failed, and it's really important. And this is, I think, so important. It must be in the context of a therapeutic relationship. All the trials that look at SSRIs, they do a weekly monitoring, so there's a lot of engagement and support and development of a therapeutic relationship in the context, and I think that that's probably one of the reasons that placebo is so powerful in trials, and that you don't get a marked difference between the medication over placebo, because they are getting very good care. And also just to be mindful that if you can't see someone regularly over the first 4 weeks, it might not be a good time to commence them, because that's an important part of their care. So in this situation, Linda, Sarah's mum's really putting the fire up, and she wants me to prescribe. So in terms of where else we can turn for helping us to decide, any thoughts about that? How do we handle the situation from here? So I've got one comment back that seems problematic. Well, yes, it did feel quite problematic, because my mum was really applying some pressure. There's Darren's made a comment about asking the patient and explaining the pros and cons. Counselling with Sarah, asking Sarah what she thinks, exploring mum's reasons. So they're all really good. They're all really good points. In terms of I think it's really important to ask the young person first and foremost. Find out what Sarah thinks about all of that. because after all, that is the basis of shared decision making. And someone's just made a comment around that. Family and friends, well, you know, if mum weren't in the room, then be keen. I always check with young people if they present on their own and medications being considered, or if they're requesting medication, to engage them around what they think family and friends' views might be, just to get them thinking about that. And might it be okay to have a family or friend, an adult friend come in and talk about that? Other times there can be therapist feedback. It might be in supervision, getting some support in supervision. And of course, there's the option of getting a psychiatric opinion, which I think is a good option in the case of someone who's under 18, and particularly if they're under 16 years of age, like we have with Sarah. So if we look at shared decision making, just quickly, so really just focusing on the key points. So it's the point of it is that it's a two-way exchange to build understanding of the young person's knowledge of treatment options and the GP's knowledge of the young person's values and preferences, as well as discussing the possible risks and benefits for each option and encouraging the young person to explore their values and preferences. And because sometimes their values might be driven by incorrect information or misunderstandings or very personal bad experiences of friends or family. So it's good to try and get a context of what might be driving that. And then it's really important to select an option that's consistent with the values, because if the young person's telling you they're not interested in medication at all and you prescribe medication, you're really likely to disengage that young person. So I've just a couple of questions from the audience. So accessing public psychiatry in rural areas, well, that can be a real challenge. I think at Headspace we have a telepsychiatry service. So for young people who are accessing Headspace centres, we're able to access private psychiatry and that way, and also there are other services that provide access to telepsychiatry. Sometimes through the PHN they might have special commission services in some areas, so it's always worth checking with the PHN about if there might be any it can be very challenging, and I guess for some GPs working in Headspace centres, there can be sometimes there's easy access to psychiatry, which is a luxury, and of course if you've got access to it, then I always think it's an opportunity to share the care and the stress that can be associated with that. Someone's asking for a copy of the PH9 questionnaire. So I'll just point, a lot of these resources are available on the Headspace Clinical Toolkit, and they're also available within the Origin guidelines. The Clinical Toolkit summarises sort of key learning points under each of the major topics and collect together a lot of useful resources. So we'll talk about that a little bit later. I'm just going to, so in terms of the benefits of SSRIs, and I think this is something that's sometimes not understood with the evidence for young people. The evidence is about, of the scale of about 6 points on a 120-point scale, severity rating scale. So it's a very minor increase on average. And in the most recent Cochrane review, that was summarised as being of questionable clinical significance, unlike in adults where there's much better evidence of the effectiveness of SSRIs in depression. So the difference between placebo and medication is pretty small. And you need to treat about 6 people with fluoxetine in order to prevent one remission. So it's worth including that into the discussion so that there's realistic expectations around the benefit and also of what you're doing if you are prescribing. And of course, most trials exclude young people with complex needs. There's a lack of long-term data, so we don't really have an understanding of what the long-term risks might be. then in terms of course, the most significant potential risk is suicidal ideation or behaviour, and how do we put that risk into context? So the median risk increases for all SSRIs from 24 to 40. So it's a doubling of a fairly small risk, so from 2% to 4%. So explaining that sort of scale of increased risk, I think, is helpful. So that most people who start on SSRIs are not going to have that problem. But of course, if a young person does have that problem, then that's important. So I've just got a couple of questions that have come up there on the side. So again about access. So there's a question about what about access and teleconferences with psychiatrists? Well, again, through telepsychiatry. So again, through your PHN, your local headspace centre, if you've got a local headspace centre, check in with them because they might be able to access telepsychiatry for you. Also, increasingly, some PHNs are offering secondary consults with for GPs where they're having difficulty accessing psychiatry. So again, with your PHN, I would encourage you to pursue that to find out what's available locally. I've got another question about what's the youngest age fluoxetine can be used. Well, I think it's really important to answer that question in the context of the evidence. So we would say that there's not very strong evidence of any benefit the evidence is of a very mild benefit above placebo under the age of 18, and I think we would presume that the younger the young person is, the more careful you would need to be about making that decision. And of course, it would depend on the context and if the young person's a mature minor. But I think generally it's good practice to try and get an access an opinion from a psychiatrist in order to be able to do that. In terms of usually the starting doses, well, with young people, they might be more sensitive to side effects. So it's usually commence at low doses for at least a few days, half a dose of what you normally commence and then increase from that. And then that's all outlined within the guidelines. I'll keep moving, otherwise we're going to run out of time. So I've just put there are a lot of potential side effects. There's a bit to go through. I put this list together, which is all of the things that you should tick off as having done before prescribing an SSRI. And I would say that I would challenge anyone to be able to do all of those things the first time they see anyone, whether they be a young person or not. So to my mind, I think it's a very big ask to prescribe an SSRI the first time that you see someone. So polling question. Because of the very clear guidance around the need for weekly monitoring, I'm just going to ask, is weekly monitoring for adherence, for side effects and for risks associated with SSRIs, is that achievable in your centre? Okay, well that's really positive. Overwhelmingly, the response is yes. So, or about 80% of respondents are saying that yes, that's possible, and that's really good because I'm aware that and there's a small number there that are saying no, and I guess in those centres, it's useful to remember that hopefully there are other people in the practice who might be able to participate in that, and that might be the nursing staff, particularly if they're a mental health nurse, or if they've got some training in the area, and of course if the young person is seeing a therapist, then it's also worth checking if they're comfortable with checking in around those potential problems with medication when they're seeing them, so that it's a shared review. So what does Sarah think about medication? Sarah's very clear. There's no way I'm going on any medication. Mum needs antidepressants, not me. Okay, so that makes it pretty clear from that point of view. does this change my view about considering an SSRI for Sarah? No, I think that's good. That's consistent with the guidelines and what I'd be encouraging anyway. So I'm very happy to support Sarah in her wish not to have medication. What if Sarah wanted SSRIs? Well, the issue there might be if Sarah wanted an SSRI, then that's a slightly different scenario. I still would be pointing Sarah to the concerns about lack of evidence and of the issues, and I would then go to my usual practice, which is I don't do it the first time. I like to review people and better engage and support all thinking about that and encourage her to try treatment as per the guidelines. So again, I'd still try and see how Sarah responds to directing her to care that's consistent with the guidelines and see how that goes. Following question, is it okay for the registrar to continue seeing Sarah? So if you're supervising someone in this situation, do you think it's reasonable for the registrar to continue seeing Sarah? Any last takers? So it looks like we've got a pretty strong yes. So 85% yes and about 15% saying that they're unsure and no one's saying no. And I think, look, I think you could say it might depend, but I think generally, given that, as the introduction to this session said, pointing out that registrars aren't getting enough access to young people, and that one of the problems is confidence, that really encouraging the registrar to continue seeing Sarah is a great way to build their confidence, even though it's a bit of a tricky situation. And as a couple of but it will also depend on their confidence. So it might be that different ways of managing that might be to sit in on a session and just to sort of do a closer supervision and just keeping really, I think certainly I would think it's very important to make sure that the supervision that you're providing is pretty close, and that you're giving plenty of time to explore the concerns that the registrar's got and consider the need for additional review as well. And when is it particularly important to get a supervisor's opinion? Like, even if a registrar is confident, in what situations would you be really keen to make sure that the registrar engaged you in some discussion around what's going on? Oh, this has come up as another polling question. So, so I think. So I think all of these is, all of these are things that if there was, so they're really about, the younger the young person is absolutely what you need to be involved in assisting the registrar to monitor that. It's complex, and there's complexity here, even in terms of the family dynamic is representing complexity. If you were concerned about bipolar disorder, if that's being questioned, or if the diagnosis is unclear, and other things that might complicate that, if there were personality features that were a red flag, or alcohol and drug use. And then in this situation where there's really strong discordant treatment views, and I would say that all of these reasons are the same reasons that you would want to be trying to get the opinion of a psychiatrist to sort of protect yourself in the situation where the family members pushing very strongly for a treatment that the young person doesn't want and is not consistent with the guidelines. So I think the responses here show that most people think that they're all pretty good reasons to be getting and the supervisor, and I would say the psychiatrist involved as well. Oh, I think we've got a repeat slide there. Sorry about that. So just thinking about other pressure points, because I think that sometimes other people besides parents can apply pressure to prescribe. And I've seen that with psychologists, young people themselves, other workers. There might be other points that are applying pressure. And I think that one thing that's really important is and that's helpful in terms of managing pressure to prescribe when you don't think that that's really what you need to do. And that's about setting expectations. And so I think so normalising practice is really important. So for example, when I have a therapist who sends a young person to me thinking that they need to be prescribed something, and that's what the young person presents with, I will normally make an effort to contact that therapist and say, look, I understand you might think that, but can you maybe just present it more broadly to the young person that you want them to see the GP and have a chat about and see what their assessment of things are, and maybe one of the things to consider is medication. Otherwise, it kind of puts you up against the 8 ball a bit. Though, mind you, if you've got a good, strong relationship with that therapist and they think that the young person might benefit from some treatment, then that's a serious question to look at, of course. There are some comments around where our pressure might come from. We've got school nurses or school counsellors, teachers may suggest prescribing medication, other doctors, for example, mum's GP. And yeah, I think that's true. And so again, some of those strategies for setting expectations can be really helpful. Always checking with the young person, and then if the pressure is coming from family and friends, just being really clear. I understand that your concerns, but then going back to I really need time to properly assess and consider, explain more the evidence, etc. So back to Sarah. So I did make a psychiatric referral, really to shore up my position, in terms of dealing with the dynamic between Sarah and Mum. A formal diagnosis was made of moderate depression with low risk and subthreshold generalised anxiety disorder. SSRI, and the psychiatrist did raise considering an SSRI, again at Mum's insistence, and Sarah declined that, and the psychiatrist also supported that. That was fine. She was happy for Sarah to continue on to further treatment. There's been another comment that it might be a young person's friend who is also putting giving either applying pressure or giving the young person an idea, and I think that's also absolutely true. Or it might be a young person who's had experience of being on treatment and suggesting to their friends that they would benefit from that as well. Family therapy was encouraged, and on the first time that it was encouraged, Sarah was pretty clear that she didn't want family therapy. She really just wanted to engage in therapy on her own, and so she did end up having a referral to another to a psychologist at the Living Headspace. Much better boundaries were set around managing Mum. Mum was encouraged to seek her own help elsewhere, and not to raise it with her issues with Sarah's therapist, which she eventually did. And then after 6 sessions, Sarah came back on review, and she even on review after the first one, which I think is really important, just to see how that's gone, given that she had a bad experience. She had a much more positive experience. She loved the therapist. She felt engaged, she felt listened to. She felt like this therapist's on my side. So, so almost instantly, she was feeling a lot better, really, because she had a safe space to kind of explore what was going on for her. And she had people who were on her side. So all of that was really helpful. Subsequently, on review, Mum was still applying pressure, and again, the issue of family therapy was raised, and it was an access issue, which we were able to address through through referral to eHeadspace. So eHeadspace is our clinical. So there's a question here about, does Headspace do family therapy? So many Headspace centres do provide family therapy. We now have 100 centres, and so increasingly many centres are building that capacity into their service. At the time that Sarah was being seen, we were able to refer her to eHeadspace. So that's our online service, which is by clinicians, and we have a family therapist within the eHeadspace team, and they were able to set up 3 telephone conversations, which both Mum and Sarah found really helpful. So, and after those 3 sessions and a couple more sessions of therapy, Sarah was feeling a lot better. She was motivated because she had to go to a school ball, and her wound healed up, and she was very proud. She stood up in front of Mum with her hands on her hips and said, "I told you I could do it without medication." So she found the whole thing very empowering, and she had a really great result. Of course, that's not the end of it, because there's a risk that she might resort to that kind of behaviour again if something distressed her in the future. So it was really important to have an early relapse prevention plan in place and to encourage early review. So I'll just, there's a question around what are the main pitfalls of registrars and what are the main pitfalls of supers trying to assist registrars. I'm not sure that I think that's a very big question. And I think in this scenario, I'm wondering if the main pitfall might be this issue about registrars not seeing enough young people, not being confident with what the guidelines are, and therefore not wanting to take on that role or being less likely to. And I think I wonder if confidence is a really big issue for the supervisors in terms of being able to support in this kind of scenario. And there's also a comment about, as I've suggested, over referring or prescribing of medications. And I think appropriate prescribing of medication can be, is really important for both registrars and even very well experienced GPs. So I think it's really important if registrars have opportunities to see young people, that they should be encouraged to take that on and provide that really supportive longer. Get that sense of what a ongoing supportive, holistic therapeutic relationship, how that works with a young person. I'm aware that we're going to run out of time. I've just got a few more slides, really just talking a little bit about what Headspace services offer. Are people okay for me to continue? And I understand that some people might need to drop out, but anything that I cover off in the last few minutes you can see in the recording, but I'll try and get through this pretty quickly. So we're funded by Headspace is funded by the Federal Department of Health, and we are the National Youth Mental Health Foundation. We've been very successful branding, free or low cost care for young people 12 to 25 in a youth friendly environment. And then, of course, what people will be most familiar with is our centres. We now have 100 centres across the country, but we also have a big presence, increasing presence in schools. So the school support program, which is got a strong foundation in post-suicide interventions, but it's now branching out into increasingly supporting schools to assist young people. There's a question around GPs getting involved in the school support program. I think one of the directions that we would like to see is that over time there will be an opportunity for more schools to have better links into Headspace centres, and then GPs will be more involved in that way, I think. eHeadspace, as I was talking about, is our, so we've got a big clinical team. So the difference between this service and most sort of online services is that we this is staffed by psychologists, OTs, family therapists. So it's all this is staffed by psychologists, OTs, family therapists. So it's all clinicians, and it's been very successful. The demand's very hard to manage. And so it's shifted from a focus of kind of replicate the service that would happen in the centre, much more to an engagement piece too. So working with young people who are not ready to attend face-to-face and trying to assist, oh, excuse me, if that's what they need and benefit from, and how to make that happen. Excuse me, I'll just have a quick sip of tea. And then some centres have a youth early psychosis program as well. There's about half a dozen of those around the country, so not many at this point. Excuse me. And so what's really kind of underpin all of the Headspace centres is that there's youth-friendly care. Entry point for all young people is 12 to 25. It's free or low cost, so the GP services are all bulk billed, and there's often co-location integrated support services on site. eHeadspace does not require a GP mental health care plan, although you know, it's not gearing up to offer 6 or 10 sessions of therapy, so it's really a small engagement piece. So most people only access a few sessions, and many young people only access one session. So it might be that they do some engagement and then they're offered enough assistance just from that, so often information, etc. 4 core services streams, so physical health, which sits right in the GP's domain, mental health, of course, we're well known for, alcohol and other drugs, and vocational educational support. So these are the 4 core streams that all centres offer services around. And GPs sit right at the heart of the Headspace model, and of course can work with the young person to navigate through other clinicians. And GP, as GPs are in the broader community, might underpin and support that young person over a long period of time and navigating. So I've certainly been a GP, caring for a young person over them seeing a number of therapists over a number of years. So that sort of long-term sort of work is certainly possible within the Headspace model. It's multidisciplinary team-based care, so there's team meetings, secondary consults, supervision usually, and shared care. As I was just mentioning, that we've got a lot of resources that are evidence summaries, guidelines, other links to external resources, information sheets that are designed for GPs, evidence summaries, information sheets for young people, family and friends, all collected in our Headspace clinical toolkit. So I encourage you to have a look at that. And we've got free accredited online training. So there's 3 ALMs, one in youth mental health, which is a great introduction, and we've got one on young people, drugs and sex, and also one coming up on developmental disorders. So there's some questions there about, does Headspace have its own psychiatrist? Well, it depends on the centre. So most centres do not have access on site to paediatricians, but many centres increasingly now have access to psychiatry on site, or if they don't have it on site, then they might do it virtually over telepsychiatry. So it's usually pretty easy to get access to psychiatry, but not to paediatrics. Most Headspace centres don't have paediatrics on site. So in terms of what Headspace GPs do, about 50% of it is mental health, and then the rest of it is a mixture of physical and sexual health, and we encourage global global care, holistic care. So we over 100 centres now, so I don't think actually this is the most current one. So there are a couple on there, a couple that are not on there. So we've been very successful from that point of view. Referral to a Headspace. I think the most important thing is the majority of young people self-refer, and so I think one of the problems that arises in general practice is that a GP feels like they've lost a young person to Headspace. So it's really important not to just mention Headspace as an option. Oh, you might think about going to Headspace. It's really important, as you normally would. If you're thinking that a young person, you would want a young person that you're saying to be seen at Headspace, write a referral letter, make a really clear reason for a referral. You know, do you want assessment? Are you looking for therapy? Are you wanting a psychiatric opinion? Get in touch with the local Headspace centre and see what services they offer, and then that will support communication and ongoing involvement in care. And then to find your nearest centre, if you're not sure where it is, you just because you can check their referral mechanisms. You just go on the Headspace website, and one of the first windows that comes up is a centre locator. Just about finished, so that's just on that site. So any questions? Sorry, I haven't left much time for questions, but we've had a few along the way. So, but if you've got any last burning ones before we finish up, that would be great. And I would thank you very much for having me again. And I would encourage you to look at some of our great collection of resources on the website.
G'day. That was fantastic. Thanks very much for taking us through that, Claudia.
That's fantastic.
Where can you find more information? Well, if you haven't had a chance to download everything from the document folder, which I'm going to highlight for everybody just now, we'll leave this chat box open for a little while post the webinar tonight, so you can download that stuff, or you can wait for us to send it out with the recording and everything else. We've put a copy of the webinar slides in there for you, as well as all of the links, etc., which we've been announcing throughout the night. It's been fantastic to have you all. If you're looking for the next webinar topic, our next webinar is going to be on GP learning road trip, taking practice education off the beaten track, and it's going to be presented by Rebecca Stewart on Wednesday, the 18th of July. So keep an eye out. I believe the link will have been sent to you via the email with the evaluation. We'd love to receive your feedback in relation to this webinar, and thanks very much, Claudio, and to Headspace for making this webinar possible.